cancer, unfortunately, hits even people who are the healthiest. And there's so many things that are out of our control in terms of cancer, like our environmental influences, especially here in the US, where between microplastics and toxins and glyphosates that we are exposed to a lot. And so our cancer risk, unfortunately, it still remains one of the top killers. And so we really do have to be very aware of this. And so obviously I'm not going to recommend people don't get screening. I think we just have to look at what is the right type of screening for the right person.
Welcome. And I'm so excited to have my favorite guest of all time, Dr. Elizabeth Yurth. Welcome.
Thanks, Zora. You guys, always love talking to you.
Okay, we've got a lot to unpack here about breast screening because I've had a couple other episodes and I'm sure every woman is really confused on what they need to do. And I want to start off maybe with mammography and understanding this as a breast screening tool. And we got so many other choices out there, the thermography, QT scans, ultrascans. We're going to talk all about this. And I want to clear some of the confusion because you're not selling anything. You're not selling a QT scan. You're not selling anything.
No problem.
Yeah. So I'd love to get your opinion on things. I know you always take deep dives and you understand the science, you understand the research, and then you have your own practice with the Boulder Longevity Institute, and you have your own clients, and you are certainly recommending them to do something, right?
Exactly. Yeah. So I think obviously when you're doing health-focused medicine, prevention is a big key, and cancer prevention is a really important part of our longevity. So it's making sure that we are doing the right things. Do we get, colonoscopies if we need them? Do you do mammographies on a yearly basis to make sure you don't have breast cancer? So I think screening is obviously critical. And I don't think you can just sit around and say, okay, I'm going to be fine if I'm doing all my biohacks and my hormones are perfect, because cancer, unfortunately, hits even people who are the healthiest. And there's so many things that are out of our control in terms of cancer, like our environmental influences, especially here in the US, where between microplastics and toxins and glyphosates that we are exposed to a lot. And so our cancer risk, unfortunately, it still remains one of the top killers. And so we really do have to be very aware of this. And so obviously I'm not going to recommend people don't get screening. I think we just have to look at what is the right type of screening for the right person.
I totally agree with you 100%. And I think the people I have interviewed in the past, they would all agree too. We can't just put our head in the sand and not be aware and talk about prevention, but not only prevention things we can do, but like you said, there are perfectly healthy people. Everyone knows that person who's perfectly healthy and do all the right things and they still get cancer. So the screening part is what I want to focus on in terms of which ones, because the one that's available, the one that insurance usually covers is our mammograms, but they're controversial. And there's some some doctors, there's people I've interviewed as well, and people in there in the influencer space on TikTok and YouTube and talking about mammogram doesn't save lives or mammogram causes more harm than good. And if this is what women have access to, then they're lost. They're like, I don't want to put myself at risk, but they know they need to be screened. And so there's a lot of things I think we need to uncover in terms of the arguments that I've heard, because I've heard both sides of the story and I can understand both sides of the story. So let's hear your take on mammograms, and should they be started in our 40s, like as the insurance says, right?
I think the problem with so much of what we do, Zora, what you and I do, is we get to this all bad or all good. And particularly when you're looking at traditional medicine recommendations, right? The non-traditional medical providers, the biohackers, are sometimes so anti-traditional medicine that they are going to look for anything bad in traditional medicine. And there is a lot of good in traditional medicine, right? Antibiotics, yes, they can have problems, but they can be life-saving. So every tool in our toolbox has risks and benefits. We always have to weigh that. So when you look at mammograms, I mean, they've long been the cornerstone in breast cancer screening, right? And now the recommendation is age 40 to up. Usually, I think they recommend stopping at 80 if you don't have a history of breast cancer. I think that's mostly because they expect us all to die at 80, so it doesn't really matter. But when you look at, is there downsides? Yes. One is that it's a very, very, very small dose of radiation. So it's not like it's a massive radiation dose, but you're taking a breath, you're compressing the tissue. So you're smashing the tissue together, and then you're doing focused ultrasound, sorry, focused radiation. So you're doing very focused radiation to portions of the breast. And if the way the mammographies work now, if there's areas that are harder to see, the radiation is actually higher to those areas. So where there potentially is pathology, there's even a little bit more focus of radiation to help the radiologist figure out if it's something benign that we need to follow up on or malignant. So in a focused radiation, which cumulative over time, when I'm focusing radiating one spot in the breast over and over again, we know that that can induce abnormal cell growth, right? So that's one piece.
Sorry, can I interrupt for a second? I just want to know, do we know what the percentage is? Because you say abnormal cell growth, and is that 1% of the population? Do you think it's 10%? Do we not know?
Yeah, it's relatively high that at any point in time, we will have abnormal cell growth. So when you look at abnormalities on mammograms, it's really as many as 50% of people can find abnormalities on MRI scans if you get detailed, or I'm sorry, on mammograms, if you get detailed enough on the exposure. And lots of times those are the things that don't need follow-up, but lots of times it takes extra imaging to figure that out. So it's a pretty high incidence of finding things. It's a very sensitive test. And that's good, right? When I'm looking for cancer, I want a sensitive test. The problem is that it probably isn't always finding cancer until it's a little bit larger. So until there is a bigger tumor there. So it misses small tumors. It does look for what I call microcalcifications. And microcalcifications are important because microcalcifications are areas where there is abnormal cells usually. So these are little calcifications that you can see that you wouldn't pick up on something like an ultrasound, that you can see with a mammogram that will then tell you, oh, there's something going on here. Let's take it to the next step, which might be biopsy. But remember, a lot of those things, like intraductal carcinomas, so what's called ductal carcinoma in situ, which gets diagnosed a lot on mammography by microcalcifications and then biopsies, in itself, left alone, 90% will self-limit and resolve, right? And yet we treat aggressively for that 10% who doesn't. So as soon as that's seen on a biopsy, you're falling into, I have breast cancer. Whereas ductal carcinoma in situ might not even be breast cancer. It's a potential precursor, yes, but a lot of times it self-resolves. So like a lot of things, it may simply be, if you followed that scan up in a year, there wouldn't be anything there. So we started changing our recommendations on what we've seen when we see abnormalities on these scans. I think that's the biggest problem is, are we finding things and then taking people into more focused radiation, biopsy of tissues, which is traumatic to the tissue. When you do trauma to tissue, you increase the risk of progressing cancers. You can see cancer cells and things like that when there is all cancer growth that your body may have gotten rid of on its own. There's a lot of downsides to the subsequent, even the mammography itself might not have that many downsides because I don't think the radiation is huge. But the subsequent follow-up of scans, which very often are totally benign findings, in fact, most of the time are benign findings, is pretty traumatic, both mentally and physically.
So
that's where the big problem lies.
So I'm sorry, I keep interrupting. So the DCIS, if 90% of the time these are benign, then what is a woman to do when she gets a DCIS diagnosis and says, am I in the 10% or am I in the 90%? And if I have to wait a whole year, if she's in that 10%, and that's pretty aggressive, no, it'll grow pretty fast. She may not have a year, will she?
Well, I think what you do then is you do more frequent follow-ups using things that will give you a little bit more information, which we can talk about. Like, are those the people now where I do follow-up MRI scan imaging, right? Where I see if there's something changing here or not. Or I do what's called Oreo scan, which is a protein marker that you can look for breast cancer that's changing. So I think those are the people that you can say, okay, every 3 months, let's do a follow-up. As opposed to, okay, let's go and do a lumpectomy or a mastectomy and then focused radiation to the breast. I think that if you look at the data, even the American College of Gynecology is starting to change the recommendations on DCIS, but it's very debated. It's a hot topic. Yeah. And, you kind of look to yourself and you go, okay, I just want this gone. When I get a lumpectomy, it's hard. And that's a hard decision. That's a very personal decision. And I think the key is to talk people through. And some people are like, no, it's a little bit like prostate cancer, I guess, for men. In that a lot of men will have a small prostate cancer diagnosed that would never kill them. right? And yet they go through radical prostatectomy, which has a very big lifestyle change to them and affects their sex drive, affects their ability to have sex, affects their urination very oftentimes. And so we have to always counsel people based on what their comfort level is. I have very many people who their comfort level is, okay, I will just keep an eye on this. I'm not going to wait a year. I'm going to keep a close eye on it. And if things start to progress, I can always act then. And I people are like, no, I'm not okay with that. I'm going to chop off my whole breast. I just want it done. I want to not have to think about this anymore. And I think that that's a personal decision. And I don't think there's a right or wrong answer. But I think the data is coming out. The DCIS is probably not something we should be treating as aggressively as we do.
So you see in your with your clients, you're seeing half of them, I don't know how many are actually cool with it and fine, let's just watch it. And the other half are going, no, I want this out of me now.
Right. I want to be done. Right. I just want this. I want to be done. I don't want to screw around with it. And they want a lumpectomy. And there's some concern. Are you, when I'm going in there and now futzing around with a DCIS, right, which is ductal carcinoma in situ. So it's actually just following along the duct and trying to cut out that piece of breast tissue. Could I potentially now be spreading these cancer cells so that now I'm actually progressing the cancer more? So there's a lot that we don't know.
Yeah.
And I think that's where you really have to just do a lot of counseling. I think myself, I probably would wait 3 months. I'd follow this up. I'd keep following it, but that becomes an expense as well, right? I'm going to have to pay for follow-up studies. So you have to look at what is their ability to pay for things, right? What is their ability to pay for subsequent MRI scans? Can they access that easily? Can they do other things? So I think that the next 10 years, we may have more data. At this point, we have to do the best of what we have, which is really giving people all the ups and downs of this data. And then they kind of go, would that have been better not found? Maybe not doing a test that would have shown ductal carcinoma in situ in the first place. Maybe I would have been better off. Maybe that's a finding that would be better off not knowing. And we've overdiagnosed it now because of the access of very intense. So we have our mammograms have now they're using AI technology. They can pick things up much more than they used to be able to. So how are we picking up things that previously never would have been a consequence, right? So we know that mammography is definitely diagnosing more cancers, but is that saving lives? It depends on the age group. Depends on who you're finding that. Okay.
It's hard. It's again, I'm surprised when you get that cancer diagnosis. Like I can imagine a lot of women going, just get this out of me. Like you have this fear around it. And, and if your doctor, it depends probably how your doctor approaches it with you too. Like probably.
And there's some oncologists who are like, no, this is cancer. And there's some oncologists who are, if you look up DCIS, is it a cancer? It's 50-50 in the literature. Is this what the right treatment is? So I don't know that we have the answer. 10 years ago, we removed all of them. Now we're getting a little bit more like, we shouldn't be dealing with all these this way. I think the best document when you're trying to decide about a mammogram is to go. So National Cancer Institute every year puts out their recommendations based on the data to date. And they do a big review study of all the data to date. The most recent one was published 10/9/24. So if you go to like the National Cancer Institute and you look up breast exam recommendations, and what they found when they summarized all the data, this is from the National Cancer Institute, this is the Mammography Society, is that there was almost no evidence to support the benefits of mammography in preventing deaths in people in the 39 to 49-year-old age group. So not substantial from the National Cancer Institute, not substantial data to support that we should be doing this. That there was no evidence that the risks outweighed, or the benefits outweighed the risks in that age group. There was fair evidence. So there was at least some decent evidence in the 50 to 59-year-old age group that it was saving lives. There was solid evidence in the 60 to 69-year-old age. So that's the group that seemed to have the best. Okay, we are saving lives by scanning people in the 60 to 69-year-old age group. There was almost no evidence in the greater than 70 age group that you were doing anything much to save lives, and you were probably overdiagnosing things. If you look at that, that's a small window, right? The 60 to 69-year-old seems to be the only group there's solid evidence. If I stretch that, there's fair evidence in the 50 to 59-year-old age. So 50 to 70, there's probably some evidence to support the mammography is saving lives, but it's not huge. we're saving millions of lives. It's a small improvement in lifespan. So if you go to www.cancer.gov and you look at the guidelines, you guys can read that. And it's nice because they are giving you, here's the data and here's what the data is saying. Here's the good, here's the bad. When we summarize all that data, this is what we came up with. So I think that's where in that 50 to 70-year-old age group, I would say at least in a 60 to 70-year-old age group, maybe mammography. I don't think yearly. And then the question is there a better test? In my mind, there is better tests. But I think this is paid for by insurance. And if you don't want to pay out of pocket for something, this is probably your only choice. If you're in that 60 to 70-year-old age group, probably doing a mammogram every couple of years is a reasonable idea because that's the only age group that really showed solid evidence.
But what about when you have the dense breasts? Because as I understand, 50% of the population have dense breasts and the mammography is not very accurate for that. It's like finding a snowflake in a snowstorm.
So exactly. And as of last year, actually really only 6 months ago, the Graphic Society said, okay, all radiology reports now have to report whether there is dense breast tissue that is impeding the result of this mammogram. They didn't have to do that. So before they could say this mammogram is normal. Now they say they have to put the density of the breast in there. So women know this was not a good scan for me. And
that's like terrible. Like you just did this and it's not accurate, but here you go. Here's some radiation just to go with it.
Problem because a large number of women have dense breasts, especially in that younger age group. That's maybe why it gets a little more successful in the older age group is that your breast tissue as you get older gets a little bit less. But you're on hormone replacements, you still might have dense breast tissue. And as many as 40% of women have dense breast tissue that to some degree that impedes the result of the mammogram. So again, another sort of, is this the best study, right? Probably we should be looking at other studies. And as I said, I think there are other really good, well-proven options. The biggest issue here is money, right? It comes down to mammograms are going to typically be free of charge for you if you have a typical insurance plan or if you're Medicare here in the US, right? You're going to get the mammogram paid for. My advice to people is put a lot of money into a health savings account and use that to pay for things because I think there is much better options for you to look than doing a mammography, which is going to be accurate in a small window of time and not if you have dense breast tissue. So probably if you're on hormone replacement, like if your estrogen levels are kept at a young level, you're going to have denser breast tissue. So I think that you're narrowing the window of people this is a really good test for, which is why I think we should look at better options. But I'm not going to say this is not something that should be done. And I use mammograms because in some women, they're not going to pay for other studies, right? And I'm going to say, okay, you need a mammogram then. You need to do some screening test. Is what I prefer you to do? No.
And there's some people I've interviewed who really likes to differentiate screening versus diagnostic tool. Screening meaning healthy people, maybe not risk, just whatever, you just screening every year. You need to find something. And that's very different because they may go, I'm not against mammograms. It's just that they're not the best screening tool. They're maybe a good diagnostic tool for certain things. And like you said, the calcifications can be found on a mammogram versus an ultrasound that may be important. Right. So it's again, like you said, it depends. Like it just depends.
And like I said, I think the other technologies are now becoming so good that, we have so many other choices that are actually now looking better than mammography for tools. Or can we use simple, inexpensive tools and then when that's abnormal, push to a mammogram. So can mammogram be our next step as opposed to our primary screening method? It's going to be our screening method when I'm like, ooh, there's something worrisome here. Let's get a mammogram because that's going to be a more definitive test. The test will be at this point, but I already know something's wrong, right? I already know there's something there potentially.
When you think about the number of women who die of breast cancer, or if you have a breast cancer history in your family, my mother died of breast cancer when she was 57. So I've been getting mammograms since my 30s. So how many people are like me? And I'm sure there are a ton of them who say, oh, my aunt had breast cancer, or whether she died or didn't die, but then I may have to get these screening. And you're beginning these screening from a really young age. And is it necessary to be doing that when you have an alternative if you're still young and again, it's so
Keep in mind,
complicated.
like, for many years of your life, you didn't really have much alternative because we really didn't have a lot of the technologies that we do have now, right?
Yeah.
So you'll have to look at, it's easy for me to look back and go, no, I wouldn't have done that because I think there's better tools. There wasn't better tools. 20
Yeah.
years ago, when you were 30, there was not better tools, right? And that's what we had. That was our tool. Now there is better tools. So perfect world. Now your daughter doesn't have to subject herself to that, right? There is other options for her. That's the great thing about our world is we're getting better technology. We just need to know the better technology is there. Because the problem is traditional medicine is still stuck in the 20-year-old paradigm, and there's better things, but it takes medicine 20 years to move forward. So the better things don't come. They're not going to be paid for by your insurance or talked about to you by your doctor because they're considered new, even though they're out. So I think that you look back, oh, well, that's bad. You've had radiation to your breast since 30. It was the best tool that you had at the time. It was the best decision to make at that time. Now, I think now I would tell you, use other things, right? Use other better technology. Stop getting your mammograms. Maybe you do another one at 60, but stop getting your mammograms on a yearly basis. I think you're probably doing more harm than good with the breast compression, the potential for needing biopsies, the focused radiation. I think you should use other tools if they're available to you. If they're not, right?
Yeah,
You're in a place where it might be much harder for you to get anything else. Then you do a mammogram because it's what you have. Right?
So let's talk about the alternatives. What else is out there that you believe in?
There's lots of cool things now. If you start with ultrasound, ultrasound's simple. It's inexpensive. We have a company called HerScan here in the US. It's all they do is breast ultrasound. They have specialized radiologists. They have specialized techs who know how to read, know how to do a really good scan of the breast. They pull up into hotels in every city and they take 15 minutes out of your time. They scan your breast, $299. And then a specialized radiologist looking at breast ultrasounds reads it for you and gets you back the information. So it's cheap. It's easy to do. It's going to be 15 minutes. It's no trauma. There's zero risk to it. And it's quite good in dense breast tissue to look for things. Where it falls short is it could potentially miss microcalcifications. Remember, microcalcifications are really pre-cancer in a sense. So lots of times it's not going to find those. It could miss very, very small tumors, as does mammogram. So both of those will miss very, very tiny tumors, right? Mammogram can find the microcalcifications. So, but if there's not microcalcifications, it's going to miss small tumors, as will ultrasound. So ultrasound has its downsides. It has limitations, right? But I think that it is a nice, easy thing that women can do. The next thing is thermograms. So thermograms use heat. So they basically strip down, you stand in front of the thing, you answer heat. You can do your whole body, you can do just your breath, because where tumor cells are going to do, tumor cells need a whole lot of blood. So they are rapidly growing cells. They're very metabolically active. So there's huge heat coming from that area. And that will occur long before there's even a lump there, right? So it's going to be able to tell this is an area of concern, even before potentially there's a cancer, or even before there's actually a lump there, right? So very cool, because it's going to say, oh, wow, there is something abnormal going on in this part of the breast. You need to look harder. The problem with the thermogram is it's very sensitive for picking up abnormalities like areas of heat. Areas of heat could be inflammation, right? Other things. They could be that there's a little lymph node chain there that's aggravated from something. So lots of times the problem with thermography is you see abnormalities on it, right? But that's great. And I can say, okay, next step, I need something. I need to look at that more carefully with an ultrasound. Or in my case, what I do is I try and get an MRI scan, because that's by far, I think, the most diagnostic, safest tool that there is.
For monitor screening breast, or
if you can pay for a yearly MRI scan, it's great for breast tissue. It picks up small tumors. It picks up microcalcifications. MRI scans are a great screening tool.
So what about you have to get injected, it's a contrast, no? It's a contrast MRI?
Not only if you see something and you want to get next steps, but you don't need a contrast MRI scan just for a regular breast MRI.
Ah, okay. So you think that breast screening through MRI is
I think
probably the best.
MRI is great. Now, sometimes it will say, oh, there's a lump there I can't figure out, right? There's something there that makes me have to do a more extensive study.
But we're talking about screening. Like, let's say like you're healthy, nothing's wrong.
So if you can afford it, get
Yeah.
a breast implant. Like I have a girl in my office. She's young. She's 29 years old. She has really dense breast and fibrocystic disease. Like every time we ultrasound, she's got fibrocystic disease. It's stupid. I get an ultrasound, she's got lumps all over the place. And so for her, like it's more cost effective for her to just pay $600 cash pay for an MRI scan and go right to the MRI scan. Skip everything else, go right to the MRI scan.
So an MRI they won't, but it's not a diagnostic. Like if you pick up something in an MRI, then you go, okay, now I'm ready for the mammogram and
now is mammogram going to be any more useful? Probably not. You can actually then do a more specialized MRI scan, right? So now you can do a more contrast enhanced MRI scan to help you figure out a little bit more about the tumor.
Okay. So what is the standard of care? If you found something in a mammogram and you want to find out more, I thought it was the next step is a biopsy, right?
Most of the time, biopsy. Lots of times, what I recommend is going to an MRI scan before the biopsy because I don't like biopsy tissue. Biopsy feeds cells. It's traumatic to tissue. So a lot of times before I ever go to the biopsy, I will get an MRI scan because the MRI scan may tell me that this is not going to need a biopsy. It does not look worrisome, right?
Oh, so you can determine what kind of a cancer it is through MRI.
Not necessarily what kind of cancer it is, but is it a benign tumor or not?
Okay.
Finding on the MRI scan that can help you decide is this a benign tumor or not.
Okay.
And you need to go to the biopsy. I always say biopsy is my sort of last resort if I can't figure it out with any other means. Right?
Okay. And so what about some people argue, well, if you have to go into the contrast, it's the contrast liquid is toxic and it's
gadolinium contrast is yes, you can store gadolinium in your body. It's a relatively benign. I think it's one of those things that's gotten a little bit overhyped. I do every now and then find people who have had multiple gadolinium enhanced studies who have high gadolinium levels. Getting an MRI scan once a year with gadolinium is probably going to have very minimal gadolinium levels for you.
Okay. So
I would worry much less about that as a toxin than all the other toxins you're exposed to.
So you have to look at the benefits versus the risk. And then there's a hack that I learned about. Maybe you can confirm that this is good. Before going into any kind of a scan, I don't know if it's MRI, anything with radiation, let's say an X-ray for your teeth, your bones, a mammogram, to take 2 to 4 grams of vitamin C, high dose, and then 300 to 500 milligrams of melatonin 1 hour before the scan, and then 3 days after. Like, does that make any sense at all?
That's probably helpful. When you look at detoxification pathways, it's probably a helpful thing to do.
Okay.
I know harm, right? And then if you're doing something like gadolinium, taking extra NAC, so you can help detoxify yourself better, right? So that's where you're doing like 2 grams 3 times a day of NAC as well to really help you detox. So I think there's a lot of hacks. I like that hack. Using vitamin C is great. So I think there's lots of data to support that. No, but is it going to hurt you? No. And might it be beneficial? Yes. So
yeah, personally, I would rather go take that if I had to.
They're cheap, easy things to do. Potentially, right?
I'm better than doing a biopsy. I've had a biopsy on my breast, like the blocked milk duct, but it freaked me out over the whole time I was waiting, like worried, oh my God, I have breast cancer. So it's traumatic. It's
traumatic. It's bad mentally, it's traumatic physically. It's not a benign thing to go through a biopsy. If you believe what our brain is powerful enough to do, can we actually, because we're thinking such bad thoughts all the time, once we are given this kind of news, can you actually change your body in a bad way? I would argue there's a lot of power to the mind. We know that you could actually, there's a great study recently where people they really just did a whole kind of using ketamine infusions and convincing people they didn't have cancer, and those people cancers resolved. They actually got better with doing nothing else by thinking they didn't have cancer. There's a lot of power to the brain. If I think I have cancer, I think it's one of the biggest fears, one of my biggest problems with my cancer patients is once you've had cancer, you are in this constant state of fear. Even if, clear bell, everything looks good, you live your life in this constant grade of fear. And a lot of my cancer patients then develop another cancer because they're living that way. You have to be able to change your mindset as well. With Thermogram, another really cool thing is there's a whole new technology now that uses AI called NARAMI, which stands for non-invasive risk assessment by machine intelligence. And so basically by adding NARAMI with the thermograms, which a lot of thermogram centers are doing now, it showed 98% sensitivity. And they did a head-to-head study with mammogram where they took people who had a lump that was known cancer, had been diagnosed previously, was a known cancer, and they ran through the neurami versus a mammogram. Mammogram picked up 2 of the 6 people with known cancerous tumors. In this 4 of them, the neurami picked up all 6. So
Wow.
you can see that even with a known cancer there, it was small. The mammogram only picked up less than 50% of them. So at small stages, when you want to find cancers, a lot of times mammogram fails, not picking the things up early. But again, you're going to put a lot of abnormalities on thermogram that are, especially with the neurami technology, that are benign.
It's like the whole overdiagnosis thing again.
Right.
So it's just, do we treat this? Do we freak
But
out?
at least if I get a normal thermogram, right, I could say, I'm pretty certain this person is good, right? And so I don't have to worry about anything else. And then I could use that as a screening tool to, but I like that if you see inflammatory changes in the breast, and sometimes when you do a full body, you'll see like people have root canal. You'll see actually on the thermograph, it lights up from the root, from the tooth down the lymphatic chain. You'll see this whole line of like hot activity. And I'm like, okay, crap, there is inflammatory stuff going on here that is going to affect your breast. Even if you don't have a breast cancer now, you are going to probably get a breast cancer there. So the cool thing about thermography is it allows me to potentially treat before I would see a cancer, because cancer is imminent in that person who has chronic inflammatory changes in a region of the breast, right? So by just the inflammatory changes, you can figure out with the thermography, I will be able to pursue, okay, I got to get the inflammation out of this person. I got to get rid of the root canal, whatever it might be, to get rid of that. So it's really cool, especially when you do like full head, neck, breast, you'll see a lot of stuff that tells you, okay, I need to focus on this data inflammation. So they're really, I still think a really useful test.
Does an MRI pick up some of that inflammation if you were to?
Well, remember, yes, it will pick up some inflammatory changes, but not until things get a little bit more severe. Not as early as the thermogram will. Thermogram's going to pick it up because it's just picking up heat, and heat occurs long before there's any pathology that you can see. MRI scan's not using heat, right? It's using bouncing photons off the tissue and seeing how many are reflected, and that's not going to pick up. Yeah, it can pick up inflammation in soft tissue a little bit, but not to the degree that a thermogram can.
How much does a thermogram cost, more or less?
If I'm here for just a breast thermogram, it's like $299. If you do full body, it's like $499. So not expensive.
But do you think that would be in addition to, let's say, self-examination or MRI or I don't know, other things? Or is it, do you think somebody can just be good?
I think you can use that as a screening tool. And if it's normal, you could be pretty certain that you're good. I a lot of times combine it with ultrasound.
So,
and one of the things I use a lot, there's something called an Oreo scan.
Yes.
Oreo, you guys have heard about gallery scans. So gallery scan is looking for abnormal methylation in your blood that cues that there's cancer cells, right? The problem with gallery scan and a lot of these other screening tools for cancer is breast cancer doesn't shed these markers into the bloodstream very well. And so whereas they're very good for picking up some cancers, hard to diagnose cancers like lung and pancreas, colon, they're very good. They're not so good for breast. They've only got about 20% sensitivity for breast. So you can't rely on a gallery scan for breast or prostate. But Oreo found that you can find those protein markers in tears.
Crazy. Yeah.
So basically you put this little piece of tissue in your eye, you sit it there for about 60 seconds, and then you send that in and it looks for these protein markers. And it's got about a 92% sensitivity rate for picking up breast cancer. So I can use that now as a screening tool, right? About 92%. You put that together with my ultrasound that maybe showed some changes or not. And now I know, okay, this is a person I got an MRI scan or mammogram or whatever it might be. These are people I need to worry about. So I think the Oreo can be a really nice screening tool as well. So lots of like with you do an Oreo scan once a year, and then you're like, oh, my Oreo scan showed something. Now I need to do a mammogram. And that's really what they designed it for, is to decide who needs a mammogram and who doesn't, right? The biggest problem with the Oreo is it's really sensitive, meaning it's going to pick up most cancers. It's also going to show up abnormal a lot of times when there is no cancer. So they wanted to err that way, right? They wanted to err the side of overdiagnosis. But if it's negative, you can be pretty confident. I don't need to go do my mammogram. It's like, as a nice screening tool, it's $159. You can you just get online, you self-order it, you send it in, you can set up a consult with the doc there to talk about it. And then that will tell me, okay, this is the person I better get a mammogram on, right? Or I better get an MRI scan on.
As I understand, It doesn't pick, it only picks up very early cancers. Like if it's later stages, it doesn't detect that. Is that true?
92% sensitivity overall. And maybe I've missed that. I don't think that's true.
Okay. What's the difference between sensitivity and accuracy?
So sensitivity versus specificity. So sensitivity means that how many of a positive, if somebody has a disease, what is the likelihood I will pick up that disease, right? So a high sensitivity means that I will pick up most people who have that disease. But if I have a low specificity, that means that I'm also likely to pick up a lot of normal people who don't have disease, and they're going to have positive tests. So you want a high sensitivity test. In a perfect world, you want a high sensitivity, high specificity test. If you're going to look at cancer, I'd always rather err to the side of having a high sensitivity. I would rather overdiagnose when I'm doing a benign test, maybe not a mammogram, right? But a benign test, I would rather overdiagnose the cases and know who I need to follow up on, even at the risk of, and I get a lot of people with abnormal Oreo scans, and I always tell them, listen, very likely this is nothing, but I want to get an MRI scan. I want to get it whenever it might be, right? So at least it leads me to say, yes, you need the test, you need follow-up. And it's so simple, right? You order it online, it gets sent to you, send it in, and it takes 2 weeks, the results back, and you got a nice answer. So that's the difference in specificity and sensitivity. You want a sensitive test, by far more sensitive, but it would be great if you had a sensitive and specific test. And unfortunately, a lot of cancer screens are more sensitive than specific.
What's the sensitivity of mammograms? Do we know?
So mammograms, again, are going to have so their overall sensitivity is about 92%. So it's about the same as the Oreo scan. And again, their specificity is relatively low too. They're going to find things that are abnormal that are not. So, but it's a little bit better than it is for the Oreo scan. So I think the overall specificity of mammogram, there's an abnormality seen on the mammogram. About 30% of those are not anything.
Did you say that the ultrasound, is that picking up for women with dense breasts, or is it?
No, ultrasound is good for dense breasts. Mammogram does not pick up lumps in dense breasts, but ultrasound is actually quite good for dense tissue, right? And then we also have a better ultrasound called a QT scan. So this is going to be kind of probably the wave of the future. I think short of MRI scan, I think MRI scan is probably a little better, but this is the best technology. So basically, whereas ultrasound, somebody, you got to rely on the tech who's ultrasound of the breast. You land the machine. The machine does a 3D ultrasound, but it also does, so there's no compression. Your breast is just sitting in there in this kind of hole. You land on your stomach, and this 3D ultrasound takes a picture. And it's using a combination of what we call transmission and reflection. So basically, you're using these waves going back and forth. So it's much more sensitive than just an ultrasound. And in fact, probably way more sensitive than a mammogram. So it's I think up to 98% sensitive, maybe even 99% sensitive for diagnosing tumors. I don't know its specificity. I don't know how many. I suspect just like ultrasound, you're going to find a lot of things that are benign tumors, right? But the downside of this test is there's 10 places in the whole world that have the machine right now.
Yeah.
So it's pretty hard to get, about $600, but
that's expensive.
Yeah.
$600. It's like an MRI.
It's not the same as an MRI scan, right? And much easier accessibility right now to get an MRI scan. So I think that maybe in the future, price comes down. There's more units put in, right? Anything when it's started out like this is going to be expensive. As there's now 100 units across the US, there are 1,000 across the world, the test price will go down. Something to keep an eye on, right?
What about calcifications? Does it pick that up? Microcalcifications?
Would probably not pick up the microcalcifications either. And that's where I think thermogram plays a role, is because microcalcifications are a sign that there is some tumor activity there. So thermography can tell me there is tumor activity or abnormal vascular activity. So we see microcalcifications because there's been some sort of cell death in these things, these rapidly growing and dying cells, which is what happens with cancer cells. So you see microcalcifications, there's some abnormal metabolic activity going on. That's also seen on thermogram. So I think if you look at perfect screening, right, do a thermogram and ultrasound, and you're going to cover a whole lot. You're going to be able to get sort of, okay, this is an area of concern. On ultrasound doesn't show me anything. I know it's probably just inflammatory concern. I'll work on inflammation in this person. How do I get the inflammation stuff out of the breast? Because it's the precursor to cancer. And then we work on that, and then we repeat it and see if we made headway on that test. So I think that seeing a combination of these approaches, right? Using, like in your case, using Oreo scan as an ongoing test, and then if the Oreo scan comes back abnormal, then you go to your mammogram or MRI scan if you can get it. Yeah.
Wow. So many choices. Is there any difference between ultrasounds? Like if you wanted a breast scan screening with an ultrasound, is there different types of ultrasounds that are better than others? Or there's standard?
QT ultrasound, I think it's more the technique. It's the person doing the scan. So you're relying whenever you're doing something. That's what the cool thing about QT scan is it's automated, right? Breath is just in this hole with a machine that's doing it. Whenever you're relying on human, there's potential for human error. So you definitely want somebody who does a lot of breast ultrasounds doing your breast ultrasound, right? If you've got your ultrasound tech that does primarily looking at fetal activity, probably they're not going to be as good as somebody who just does breast ultrasounds. That's why I like the Yurth scan, because it's all these people are trained to do is breaths, right? They just breast all day long. So they do. So I think that you are dependent on the skill of somebody. And so if I have the breath and I missed a spot, I maybe missed a diagnosis, right? So I think it's more the skill of the ultrasonographer than it is the equipment being that different.
So the Yurth scan, actually, because this is how actually I figured out we got to do a podcast on this, is I got a newsletter that's the one you are using, and guessing they come to your clinic and then they do this.
If we come here for a day every year, come here and people can sign up, and it takes 15 minutes, and that's little tech does all day long. And then radiologists are also specialized in reading these breast ultrasound as well. So you feel pretty confident that you're getting a good scan, and it's inexpensive and it's easy. And you can basically, you walk in your street clothes, take your top off, and you're done in 15 minutes. So it's a really nice option as a screening tool. And like you already have fibrocystic disease, like one of my girls who works here, right? Her scan came out abnormal. We probably should have just skipped it and gone right to MRI scan, because our next step then was to do an MRI scan. Yeah. And the MRI scan looked like a benign cyst, so we can stop there. But
you could find them easily around the U.S. Is that correct? They're around. It's not like a QT scanner. You can't find it.
They're all over. Exactly.
Okay.
Yeah. And again, I love using that Oreo scan as a tool. If you guys want God, I'm lazy, I don't even want to go get a Yurth scan. This test gets delivered to your house, and you do it in 1 minute and get it sent in, and you've got an answer in 2 weeks. I think that at least that's a really great point, that there's nobody who should not be doing these kind of screens, right? That's so simple. And it makes $59.
I just got off the line with one of our members in our membership group, and she was like, she's never done a mammogram, never done any screening. She's 54. And she's like, well, I have no family history and I'm not concerned and whatever. I was like, well, you should at least do self-examination. Okay. But she would be a perfect candidate, just who doesn't want to even bother, doesn't care, but just do the Oreo scan. And like, that's simple.
And I will comment, and I'm not going to advocate that nobody should not do breast self-exams, but the National Cancer Institute found that breast self-exams did nothing to prevent mortality from breast cancer, because you cannot really feel a lump until it's pretty large. Yeah. By then, most of the lumps people find are benign, but if it isn't benign, more than likely it's a pretty progressed cancer by the time you actually feel it. So even though, yes, they were diagnosing with, and that's good, at least they diagnosed it, but it did not change mortality, which is why you want a test better than, which I say, you can't rely on your breast self-exams, even if you're great at breast self-exams. Even when they took people, the National Cancer Institute took a group that was untrained in doing it, and they trained a group, and the result outcomes was the same. They did not see a change in mortality or morbidity by the breast self-exam. So I don't think you can rely on that. You're going to find tumors too late. And our goal is to find these cancers at a very, very, very early stage. And that's where I think using things like thermograms and Oreo scans and what's going to help us find these things early, which is really when you want to find them. So I would encourage people, the breast self-exam, okay, but if that's the best you're going to do it, but it's not a great thing. And so if you want to do nothing else, it makes no sense not to do an Oreo scan. That's silly to me.
Well, the Oreo scan, I think, is only in the U.S., right? Or
I think they ship all over.
I have to go get one.
It's all over.
When I first heard about that, I was like, that's kind of a no-brainer. I got to get some, at least test it out if I can get it in Spain.
Yeah, no, I'm not positive, but I'm pretty sure they send to other countries as well.
I mean, if you can get a blood work done, like, and sent it in the mail, I don't see why
And
tears.
the tear protein should be more stable than the blood work. Like, you don't just send it back on ice or anything.
Oh, wow. Wow, this has been such a great conversation. I'm super excited. I'm really excited because after a lot of these interviews, I was just like, Jesus, now I'm so confused.
Right, what is the answer? And again, I don't know, we're still leaving people a little bit confused, but what I do with my patients is I have them do ideally an Oreo scan and a HER scan. I put that information together. Next step, I go to MRI. If I have somebody who has a cancer history, I go right to MRI scans. I just MRI scan them yearly if they can afford it. If they can't, then I'll do Oreos. If the Oreo is abnormal, push them to mammograms. I don't like to do mammograms consistently, except it's better than nothing.
Yeah.
Right. If that's the only test that people can afford, the only test they can get, then they should do. But I think there's other tests out there. So that's what I do myself. I actually do thermograms pretty consistently too, because I think that they provide me, and I do total body, because then you see inflammation, right? I'm like, wow, what's going on? You can see inflammation in your teeth. You can see inflammation in your muscles. You can see. So thermograms are pretty interesting because you get a lot of data.
Because you can take an HSCRP test, a blood test, and you get inflammation. Right. You're like, I don't know where that is.
Where's that coming from, right? So that isn't really, when I see these high C-reactive proteins and I don't know where that inflammation is coming from, oftentimes that's exactly what I'll do is I'll say, let's get a thermogram. Let's just see if it points us somewhere. Tooth pathology plays a role, right? We know that. We know that dental stuff is so important. But so often you see like freaking the jaw light up and then this whole lymph node chain light up.
That's crazy.
You know,
crazy. Yeah. And I'm wondering if certain things like HSCRP, I've been the whole time I've been with you and trying to deal with this osteoarthritis. Every time I take an HSCRP test, it's like 0. It's like so low. And I'm like, I know I've got inflammation in my hips. I can feel it.
I mean, the T-rex protein doesn't usually go up with arthritic inflammation, less than inflammatory osteoarthritis, not quite so much as it does like rheumatoid arthritis or something like that, which is more multifocal joint arthritis. But usually, interestingly, when you have just one joint, like you hurt your knee and it's inflamed, you don't see C-reactive protein go up that much. So C-reactive protein is great for looking at systemic inflammation once it's gotten more all over the place. It's not so great for saying, oh, this person has a bad hip.
That's why we got
a good marker, but it's not a perfect marker for inflammation. Unless you'll see normal C-reactive proteins, and then you look at a thermogram like, Jesus, the patient has horrible inflammation.
Yeah.
Right?
And then exactly where it is. Like that's
where it is, right? Where to target.
Yeah, exactly.
I mean, I'm shocked how many times now.
It's crazy. So I've got a lot of scans to take. I'm excited. I'm going to know what I'm going to ask for Christmas. My family always knows to get me cookie stuff like that.
I do. Thank you.
I love it. Well, if anybody wants to have more information about you and honestly, you are just my go-to doctor when I'm so confused. I don't know. I know you're unbiased. I know you got great experience. You've got all the credentials. This is why we do so many interviews with you and everybody loves you. And the way you explain things, hard science, you can make it easy to understand. Everyone can find you on your website. It's the boulderlongevity.com. And from there, you'll find Facebook, Instagram, all your information there. And what I do absolutely have to talk about every time, I absolutely love it, is your live Q&A sessions with the Human Optimization Academy. That's part of my training. That's part of my education is I learn so much from you, and you have this every month. In addition to the courses that you have, and the Labs 101 is the best, and at BLI.academy. And I'm going to have links to all of these in the show notes. So I just love what you're doing.
The Q&As, guys, are like these questions people come up with. Are you always amazed? And so like some of these questions are like, holy cow. Really smart people out there who ask these questions. I'm like, holy cow, they challenge me a lot. So they're really fun because they're like they're really good information. But sometimes stuff you would never even think of. And sometimes it's basic stuff, but a lot of times it's like, wow. Really, so I love them too, because I always learn something.
Yeah, they're great questions. Things that I would never think of. And just really fabulous. Keep doing that. I highly recommend people to go and join and you give so much information. I love you so much. Thank you so much for everything. And I can't wait to see you again.
All right. Bye, guys.